Now we move on to the panel discussion on cerebral palsy. Faculty for this session is Dr. Monika Sharma, and the panelists are Dr. Vibhu, Narad, Dr. Mahesh Narayanan, and Dr. Priyadharishini. We request the faculty, Dr. Monika ma'am, and the panelists to please occupy the dais.
I'm happy we are on time. We are actually 4 minutes before time, so we can take this time to settle down. And I'll request the panelists to please pull the chairs a little forward. I just have a feeling that one of you might topple off the stage. So today morning we are starting with a panel discussion on a very important topic. Even though CP is a topic that we have been learning from the time we were doing our MBBS and our post-graduation, I feel there are still certain things which are under cobwebs and we need to have a little more clarity. And it is great that today we have with us, I don't think I need to introduce myself a lot, but I'll just say that I'm a professor of pediatrics at Christian Medical College, Ludhiana, and I've done my master's in pediatric neurodisability, which is why probably it is considered appropriate for me to be taking care of this session. But I think we have a very interesting set of panelists with us. We have 3 people who are all pediatricians, but one of them represents the general pediatrics group, another is a developmental pediatrician, and the third is a pediatric neurologist. All 3 groups of pediatricians are involved in taking care of cerebral palsy, and therefore it is great that we will be having opinions from all of them. So we have with us Dr. Priyadharishini. She is a senior assistant professor in pediatrics at Institute of Child Health and Hospital, Madras Medical College, very much from here. We also have Dr. N. Mahesh, who is a pediatric neurologist. He's an active member of various chapters of neurology and American Academy as well. And he has been a faculty in a lot of conferences, and I'm sure that his inputs today are going to be really valuable for our better understanding of cerebral palsy. And we also have my friend Dr. Vibhu Narad. She is a developmental pediatrician from Ludhiana, and she is also a very active member of the North India Cerebral Palsy Association. So I think we are going to have rich contributions from everybody. I'll start with a very brief introduction of what is cerebral palsy. We all know about this, but it's difficult to label a definition as CP. So what I've done here is I have picked out words from the 2 books of pediatrics that we generally read. One is Forfer and the other is Nelson. And the words that define cerebral palsy is that it is a neuromotor disorder. Neuromotor meaning that it's a neurological disorder which is related with motor, which means that people who have CP have problems with movements. So this is a dynamic disorder. We generally read that it is caused by a static injury. So the words static and dynamic seem to be 2 opposite poles of the spectrum. But what we need to be clear about, which we tell our students, is that the injury is static. It doesn't change over time in the brain, but it is dynamic in its phenotype. It presents in various ways and in various forms as the age changes. And even though it is a motor disorder, you will see a lot of associated problems arising out of it. Where do I focus this? Can we have the next slide, please? So this slide is talking about the etiologies of CP. Even though a lot of cerebral palsies are idiopathic, if you talk of the reasons, being born early, being born with a small size, going through any kind of injuries in the antenatal period, whenever a mother is suffering from any problems, any kinds of infections, congenital anomalies, anything that damages or creates a problem for the development of the brain during the developing stages, which means up till the age of 4 or 5 years of age. These are the conditions which can cause problems to the developing brain and result in motor disorders. Okay, am I audible at the back? Can I have the next slide? This is not really helping. Okay, so this is just an example of how we classify CP. CP is often classified functionally and topographically. When we say topography, it means what part of the body is involved. So depending upon where the damage has happened to the brain, whether it is the motor area or the premotor area, whatever area is damaged, which part of the homunculus is affected, that affects the topography, whether it is going to be hemiplegic, monoplegic, biplegic. So that is how we can define what are going to be the clinical presentations. And the more severe the CP is, functionally as well as topographically, the more is the chances of having multiple disabilities and comorbidities, which will complicate the management of cerebral palsy. So with this, I think we can move to the next slide. And my one of the things that I just mentioned was about comorbidities. We had a research which was published and later presented in an international conference, which had something similar distribution of the comorbidities. Even though we say that this is a neuromotor disorder, you will see a lot of audiovisual, behavioral problems, epilepsy, and the more severe the CP is topographically, you expect more number of complications and comorbidities to be present. So with this, I think we'll move on to why we have this panel. The reason we have is that the number of cerebral palsies and disabilities is very high. There are almost 18 million people who are living with cerebral palsy. Within India, the incidence is 3 per 1,000 live births. And if you talk of the proportion of the total disabilities contributed by cerebrals are because of CP and disorders of the brain. So this is why we need to understand what is cerebral palsy and how we can intervene, because this is not something which can be really treated. So I'll start with my first question to Dr. Vibhu. So my question to you is that when a baby is born, we were discussing about the various causes and etiologies. How do you identify that this is the child which I will need to for possible development of CP?
Thank you, Dr. Monika. Good morning, everyone. Following up a child, since we know that incidence of cerebral palsy is 3 per 1,000 live births, but then singling out children to be followed up is important. And these are all the high-risk newborns or the NICU graduates who need to be followed up. A baby who is less than 1.5 kg of weight or is less than 28 weeks gestation has a 70 to 80% more chance of landing up with cerebral palsy compared to a term newborn who has more than 2.8 kgs of weight. So these are the babies who have had perinatal asphyxia, hyperbilirubinemia, they are premature, they are IUGR, mother has had problems, some sepsis has been there, and maybe some vascular event has occurred, some metabolic problems like hypoglycemia, hypocalcemia, seizures have occurred. So these are the ones, some genetic problems may be there. There may be twins or triplets. So generally these are the kids we need to follow up. And following up is easier if we follow them up with the vaccination schedule, because then they are definitely going to come to you. And at that time, physical examination, neuromotor examination, easiest usually what we say when we are trying to follow up, easiest is to do a TDSC screen, because there is something called monitoring, developmental monitoring. There is a developmental screening, and the third is developmental evaluation. CP is mostly going to be not obvious at birth, but 50% of children can be identified by 11 to 18 months of age. So follow-up is very important. Developmental monitoring can be done by anyone, even parents or an Anganwadi worker. Developmental screening would involve a few particular questions, wouldn't take really long, but that way we can identify which child needs to be evaluated. And developmental evaluation would be probably done by a developmental pediatrician or a neurologist or a skilled physiotherapist or occupational therapist, and they are the ones who will definitely be able to tell us that this is a neurodevelopmental disorder or cerebral palsy in this case.
Yes. Taking on from that, I remember we had done a research in our own hospital where we were trying to look at how the babies who are defined as high risk at birth are followed up and what is the compliance. And what surprisingly we observed in our study was that most of the pediatricians who were following the children, what we did was we took out the files of all children who were labeled as high risk, And we looked at the doctor's notes for 1 year up till 12 months of age, and we realized that more than 50% of the times the pediatricians had not even asked a question pertaining to the developmental status of the child. So not just the reason that the patients are not coming regularly for the follow-up, we also observed that the problem lies within us because we are not really giving importance to development. And it is important to realize that at least for the high-risk babies, assessing a development just by asking a few important questions is very good. And I'll just share this with you, TDSE. This is what ma'am mentioned about. It's a very simple chart to use. And it is mostly with a few questions, so you could just have a little bit of things with you like a torchlight or maybe a keychain. What is your experience in using TDSE?
TDSE is very easy to use, Monika ma'am, you are right. TDSE is very easy to use. Even if you train your staff, they can use TDSE and come to you with, and then somebody else can follow up. So it is easiest, if you ask me, it is easiest to follow up a child, to screen a child on TDSE. We have both kinds, 0 to 3 and 3 to 6 years.
Yes.
And it's very easy to keep it in the OPD and follow up on this.
Yeah, so what we do is we have the chart as a printout and we put it in files of every child who has a high-risk marker. What is your experience, Dr. Priyadharishini?
Ma'am, we use TDSE in our early development screening
Okay.
OPs.
Yeah.
And once we train people, as madam said, it doesn't need a physician to do. And so when we train our primary care providers, they can even do it in the community, which will help in early picking up of children. Even if they don't come to us, we can go to them.
Yes, yes. Okay, I also have this image of Hein. Any experience with this scale?
Hein, Dr. Monika, Hein has to be done by either a pediatric resident or a consultant. So Hein, so like I said, developmental monitoring, screening and evaluation. So Hein is part of the evaluation. Hein is part of the evaluation, and when we are asking anybody to do Hein, we should not expect them to know everything, just like that. You have to have people who are video trained. You have to have these charts displayed, even for all the residents. Nobody needs to remember what is this, what happened, what. No, you just look at it and mark. There was a study which was done in PGI Rohtak, and there they trained the residents. So residents and pediatricians, consultants, they individually they evaluated children on height, and the results were comparable. And those pediatric residents, they were trained on video and otherwise also. So that shows that if you train people on Hein, you get results as good as the trained pediatricians. So yes, Hein gives you the likelihood of developing CP, Hein, and starts 2 months. So 2 months is quite early. Starting at 2 months is quite early, and Hein evaluates the cranial nerves, the posture, movement, tone, deep tendon reflexes, even milestones and behavior, if you exclude the neurological examination. So yes, in the evaluation, Hein is invaluable.
Okay, so my take from Dr. Vibhu's description would be that developmental screening is easy. Developmental monitoring is not difficult. You need a little bit of training and it can be done by anybody. And you can feel free to go to the Google website and look for this Hammersmith scale. It includes assessment of the passive angles that we teach our students about, the Amil Tyson angles. It also talks about the complete neurological assessment as well as developmental staging. So if you do all these things together, there is a scoring with the Hammersmith scale which gives you a relatively reliable idea of whether this child is deviating from normal development and is likely to develop CP or not. Am I right about that?
Yes, very right.
So we'll move on from that, and I'll ask you, Dr. Priyadharishini. Now I want inputs from a general pediatrician. Now you have children who have high risk. We have discussed about how we are doing screening, and we have identified children who are going to be deviant, and we are thinking that, okay, this child is probably developing some form of cerebral palsy. So how do you suggest we proceed with the diagnosis? When would you say that this is CP, this is not CP?
Yes, ma'am. As ma'am said, we initially, at the time of birth itself, we are able to stratify the children as high risk. And once we put them in the high risk category, the IAP development consensus position paper tells that we have to monitor them more earlier than the normal children. For the normal children, it is around 9 to 12 months we have to screen once, and then between 18 to 24 months, and again at 5 years. Whereas for these children, they are telling once at 4 to 6 months, and then 9 to 12 months, then 18 to 24 months, and after that annually till 5 years of age, and then again once at school entry. So in that way we can make sure that they come to us for the high risk newborn visits. And then what they tell us, during this developmental screening, as madam said, only standardized tools like TDSC or Denver has to be used for monitoring. And with regard to when we tell that the child has cerebral palsy, we all know this has been a debatable question for literally decades, with the different values being given during different periods of time. Traditionally, it was said that it is very difficult to tell the child is having cerebral palsy less than 2 years of age. So the Surveillance for Cerebral Palsy in Europe, they published their study in 2000, and they said at around 4 years or 5 years, we can tell that the child is having cerebral palsy. But then came a study, a systematic review in 2011 by McIntyre et al., who said cerebral palsy, do not delay. They said it has to be done as early as possible. Now this systematic review by Novak et al. In 2017, they are able to give us some concrete values. That is less than 5 months of age, they tell, with the tools or like general movements assessment and Hein, as madam said, and also with MRI, we'll be able to predict cerebral palsy with reasonable accuracy. And the same, less than 5 months, GMA and Hein they have suggested, and more than 5 months, it is Hein and MRI, because GMA can be done only up to 5 months of age. And they have also suggested us how to name the children if we are not able to tell them it is cerebral palsy. Like there is no age to diagnose if the child is having concrete evidence of motor impairment. Like the child age appropriate motor milestones a child has not achieved means at any age the clinician can tell this is cerebral palsy. But still, if still we have a doubt, always it is as early as possible to put the child in early intervention. If still we are having in doubt, we have to name them as high risk of cerebral palsy. To tell high risk of cerebral palsy, the child should have motor impairment, and in addition, either there should be some neuroimaging finding which is suspicious of cerebral palsy, or a clinical history showing some sentinel events. Either of them is acceptable. The bottom line is, whether we give a name or not, the child should get early intervention so that we don't miss the opportunity of the neuroplasticity which is maximum during the first 2 years of life. Was there another question in that, ma'am?
The question was, when would you say
yes,
that
ma'am.
the child is having CP?
The take home will be probably like when we have got concrete clinical findings, anytime we can say a child has got cerebral palsy. When in doubt, we can name them as high risk for cerebral palsy and follow them up with early intervention. With regard to confirmation of diagnosis of cerebral palsy is a clinical diagnosis. So always clinical. Investigations, we'll discuss later, ma'am.
Yeah, you can speak about it. What investigations would you recommend?
Yes, ma'am.
I think somewhere you mentioned neuroimaging, so I'd like to know more about that.
Yes, ma'am. So with regard to investigations, our aim of investigating is to identify the etiology, to assess the comorbidities, then to look for findings which might suggest that it is probably a CP mimic and not a cerebral palsy, and also to help in counseling.
Can I have the next slide, please?
Manoj,
Next slide. Yes, please continue. No, it stops in between. Yeah.
Yes, ma'am. To identify the etiology, first and foremost, neuroimaging. In neuroimaging, more than the CT, MRI is more valuable, because CT is better to identify only calcifications or obvious findings like hydrocephalus. Whereas in MRI, we can even detect early findings, and MRI has, of course, the advantage of less radiation. And the recent published literature also help us to prognosticate about the cerebral palsy with the MRI findings. Findings like bilateral lesions, bilateral periventricular hemorrhages, bilateral cystic periventricular leukomalacia, then extensive basal ganglia involvement are all set to prognosticate for a non-ambulant cerebral palsy. Whereas unilateral lesions, non-cystic PVLs, they all are set to prognosticate more towards ambulant CP. And then apart from neuroimaging, the other investigations would be an EEG if the child has a history of seizures. Routine EEGs are not recommended as of now, and especially if there is a history suggestive of any particular epilepsy like infantile spasms, the EEG is said to give more value. And the other etiologies like to treat treatable causes like hypothyroidism can be ruled out with a thyroid screen. And in our history and MRI findings, if anything doesn't correlate clinically, we can go for a genetic workup, we can go for IEM workup. And more important, to assess the comorbidities, an extensive visual assessment by a neuro-ophthalmologist to detect conditions like strabismus, where the intervention will help to increase the quality of vision later on after surgery. And other cerebral visual impairment, where early vision exercises are said to help the child, and hearing assessment. And then
I think there's a lot to do, and if we are thinking of particular etiologies, I think from your discussion, my take-home message would be that a basic, complete, detailed history is very important.
Yes, ma'am.
Because that is going to help you identify what etiologies we are considering, and for that, what investigations we want to confirm the diagnosis. And one thing very important, which I like that you said, is CP is a clinical diagnosis, so clinical assessment is very important. So within the clinical assessment, what is the importance of doing GMFCS, gross motor functional assessment?
Yes, ma'am. In the surveillance of cerebral palsy in Europe, they have given a common language where when a physician examines the child in Australia and writes, this is the classification as per SEPE and this is the GMFCS score, a physician in any other part of the world will be able to understand the language. So they have made it easier for us actually. And this gross motor function classification system, age-wise is there, less than 2 years, 4 to 6 years, and 2 to 4 years is there. And like there are 5 stages in that. Stage 1 will be they walk without limitation. Stage 2 will be they walk with limitation. 3 will be walk with the help of a handheld mobility device. 4 will be the limitations are there, but they can self-mobilize themselves with the help of a powered wheelchair. 5 will be they are entirely dependent. They have to be wheeled around.
Right. So GMFCS is more about grading the severity of a child, and I believe there are GMFCS charts for different ages, 0 to 2, 2 to 4.
The E and R.
Yes, ma'am.
The GMFCS is, it's not about all these movements, they are not about the capacity, they are about the usually what the child can do. This is important.
Right.
You don't know kitna kar lega, how far the child, no. It's not your capacity which you exhibit, it is the usual thing which you do every day.
That's a very important point in doing GMFCS. But would you recommend an average pediatrician, like you and me, or people sitting here, to be doing GMFCS on a regular basis for all children with CP?
See, developmental pediatricians cannot do without it, because when we grade a child, the physiotherapist, the occupational therapist, all these people, they can understand what we are talking about, the orthopedic surgeon. We closely work with orthopedic surgeons also.
Right.
So they are the ones, and one thing this. Secondly, what we have to understand is that after 5 years of age, a child is not going to, or a person with CP, a child basically at that time, is not going to improve upon the GMFCS score. If by 5 years of age the GMFCS is grade 4, the whole life this person is going to be needed help in mobility. So these are a few things which we need to be very careful about.
So GMFCS is not just guiding your therapist, it is also guiding you as a pediatrician what to speak to the parents. Because many times we have parents coming and asking, is my child going to be normal after a few years? So when you know that a child is at GMFCS grade 4 and 5, you should refrain from that usual Indian tendency of saying he'll be fine. Because we generally have this tendency of saying positive things. So when you see that the grade is 4-5, you know that this child is not going to improve. And what we have from this discussion is that it is important to make a clinical diagnosis. It is important to take a history so that you know what investigations need to be done. If you want to label or make a diagnosis of cerebral palsy, definitely you need investigations to be sure. Going back to the definition that this neuromotor disorder is because of a static insult to the brain. Remember that the definition of the disease is very important. And clinical is what we see which helps us in recognizing, and therefore the importance of your words. It's a clinical diagnosis, it's clinical, but there is always a different side to the sword. When you're saying you're making a clinical diagnosis, there are high chances of making mistakes as well when you don't have a supporting evidence. So I am sure that Sir has something to say about that, that clinical is not the answer. There is something else which might be happening. So what has been your experience and what are your suggestions?
Good morning. So the thing is, I used to tell my postgraduates, am I audible? Okay, I used to tell my postgraduates, before prescribing any drug, they should know, before knowing the indication, they should know where it should not be given. Like carbamazepine or phenytoin in absences. Likewise, before making a diagnosis of CP, you should know what is not CP. See, presently, when we were students, the literature will talk about national perinatal projects, and even 40% of CP imaging will be normal, still they are CP and all those things. Now, presently, the genetics, metabolics, and radiology are so advanced that there are those normal imaging and normal parameters by investigation were turned out to be some treatable, some non-treatable metabolic or genetic disorders. For example, if you you would have observed, the incidence or prevalence of CP remains the same, though the healthcare is so advanced for the past 3 or 4 decades. So it indicates even otherwise the incidence remains the same, but diagnosis there are chances that the outcome of metabolic disorder is more, and there are some genetics in the pipeline that some susceptibility gene for CP. Some parents, some mother are susceptible for cerebral palsy, so that they are now working on that, finding out so that the gene splicing, gene editing is on the way before the baby is born. That is one part. The thing is, before making a diagnosis of CP, you should know whether is it CP or not. You should ask yourself, because if there is no classical risk factor for CP like low birth weight, peripartum asphyxia or antenatal issues, so you just think twice labeling them as cerebral palsy. Number 2, when there is any family history of cerebral palsy, other twin having cerebral palsy, or one among the family members having spastic diplegia or quadriparesis, think of some genetic condition other than cerebral palsy, because family history usually excludes cerebral palsy. Number 2. Number 3, suppose while investigation, if you see the progression of symptoms, it is not cerebral palsy, though the myelination may cause apparent progression in a child with cerebral palsy. For example, as myelination advances, the ataxia may be apparent only after 1 year. So in such case, the child may develop ataxia where it is actually not. Then number 4, any child with regression of milestones with history suggestive of CP, you take it with a pinch of salt. It may not be a CP at all. But the progression of increase in spasticity can also mimic a regression. So you should be very careful in distinguishing. And any dysmorphic features and isolated symptom like isolated spasticity, isolated attacks, usually we say CP, spastic, dyskinetic, all these things, usually they are a combination of, usually there will be some additional clinical sign. So if it is not there, you just evaluate those child for some other treatable cause. Similarly, eye movement abnormality, any nystagmus with hypotonia, nystagmus with dystonia, they may give you a clue for any associated optic atrophy or disorders like Pelizaeus-Merzbach's disease. And optic atrophy or retinopathy at the onset, what we see is, suppose if the child had a neonatal hypoglycemia and occipital gliosis, they can go in for secondary optic atrophy. But at the onset, within few months, if you are able to document optic atrophy, evaluate those child for other treatable cause and investigate further. And subsequently what happens is, normal neuroimaging does not exclude any other metabolic disorder. Now what happened is, in hereditary spastic paraparesis, neuroimaging was initially said to be normal. Now they have come up with some new signs called ear of the lynx sign, which may indicate a particular type of hereditary spastic paraparesis diagnostic clue. Sometimes you may pick up a diagnostic clue for Joubert syndrome by neuroimaging. And What happen? You look for, suppose the MR imaging is not showing perimetrial leukomalacia or showing some non-specific changes, still investigate further with genetic or metabolic workup if the clinical picture is not correlating, as madam said.
I think glutaric aciduria is a very classical CP mimic which presents with spastic diplegia, and it could be familial. And in some type of hereditary spastic paralysis, usually we do HSP plus, they will have associated optic atrophy, associated symptom, etc. But usually they present in adulthood, but as early as at the age of 10 years, some specific mutation in HSP, they can present in infancy, they may present as spastic diplegia. Similarly, some specific dystonia, they may present as foot dystonia alone, and they may mimic cerebral palsy. So, and for example, you know the bioactinase deficiency which can present as alopecia, refractory seizures in early childhood. But of late, what happens is they may present as spastic diplegia. If you take an MRI, it will be normal. But if you take an MRI of the spinal cord, they may show oic changes. So this is a treatable condition. So until you know what the mind does not know, eyes will never see. So until you know these conditions, you will miss these diagnoses. Similarly, ALD, MLD, by imaging you can clearly make out, that may appear early. And then specifically, there's a cold 4A related spastic CP. There are a group of cerebral palsy, they can present as neonatal stroke. Any child presenting as the stroke in the newborn without any etiology, look for this gene because they may go in for spastic CP. So all these things you should know before proceeding further. And similarly, what happens is, this is dopa responsive dystonia. It's an easily treatable cause. So until you think of that, you will miss it. Even in fact, I used to put a trial of low dose of levodopa for all my patients with spastic diplegia, even if they diagnose CP, so that I will never miss. Sometimes genetic can miss until you are clinically strong, you will miss these diagnoses. So this glucose transport deficiency, we know early that they can present as recurrent encephalopathy, recurrent seizure, all these things. Later, atypical findings, they can present as dystonia and spasticity. So until you know it, you will miss the diagnosis. And similarly, the cerebral creatine deficiency and folate deficiency late age can present as spasticity and dystonia. And these are the conditions which can present as ataxia. So for example, in ataxia telangiectasia, ataxia alone can be there. Telangiectasia may be visible only after the age of 3 years. So till then you may be labeling the child as CP. Later, the child may develop telangiectasia, then only you will know. The clinical clue is the child will have recurrent infection. And then so if you are not sure of diagnosis, as madam said, don't label the diagnosis cerebral palsy. Otherwise, you will miss your tendency for further evaluation. And I already told you Joubert syndrome and some mitochondrial myopathies, MSUD, they can present as spasticity and movement disorder, which are sometimes little static in the initial phase. So you should think all these things before the diagnosis of CP in any child. And because spastic CP is the commonest form, I think if you see a child who we are labeling as CP, but has ataxia, dystonia, some other tone abnormalities other than spasticity, I would think of mimics much earlier than for spastic CP. Thank you. That was a very interesting discussion. And I think we have this
This
example.
is one of the, even 8 or 9 years ago, this was published in Telegraph. The Charity had discovered he does not have cerebral palsy after 15 years. He got to know when his son got the same findings and he was evaluated further with orthopedics and then management, and then he said, I am happy that I am not having the diagnosis of CP. So this was way back 15 years, but now with the advent of genetics and metabolic, we are diagnosing earlier.
Do you have any interesting experiences with CP mimics?
Not exactly CP mimics, but I would, there was a study which I recently read. So this was a retrospective study in which it was done from 2015 to 2019, so fairly recent. And it was done in China. There were 207 participants who had cerebral palsy, and whole exon sequencing was done. And 78 had some or the other form of mutation in that. So almost 1/3 participants who were labeled as CP had some problem, some mutation which was seen. So I was actually reminded of that study because it's quite, it's fairly recent. But to sum up, yes, definitely if the weakness is progressive, we should be alert. If there is family history, we should be alert. If all the investigations are turning out to be normal, nothing is being showing, we should be alert. Progression, definitely. Family history, definitely. We should look at some other muscular problem, metabolic problem,
Right.
tumor in the CNS. Yes.
I think one of the reasons why the number of mislabeling may be slightly higher is the medico-legal implications and the fact that the government provides with disability allowances and we have disability certification happening. People would like to have the advantage, the justified advantage. So people or parents rather would want their child to get a certificate. So I think we should not be bending under the pressure from the parents asking for a disability assessment. If we have anything in mind that makes us feel that probably this is not CP, we don't want to end up being questioned after, let's say, 10, 15 years, saying that you have been giving disability allowance to a child who is not actually
Or
CP.
50 years.
Or 50 years. And very soon this is going to happen in India because the number of insurance companies is increasing, the medical litigations, people's awareness of medical legal issues is increasing. So I think it's very important to understand what are the conditions which mimic. But what would you do? Let's say I ask you, Dr. Priyadharishini, if you have a situation where you are thinking that probably this is not CP, but a parent is insisting on a disability certification. I remember you mentioned giving the tag of high-risk CP. What would you do with that child? Since I work in a private setup, I want to know your opinion. In a government setup, how do you handle a parent asking for a disability certification when you are not sure?
Ma'am, usually this question of disability certification comes when usually at school entry, because that is when they want to put the child in special schools, and many times they don't think of that certificate till the child comes till 10th standard. When to write the public exam, they want a certificate allowing them to have a scribe or some extra time or use calculators like that. So in our setup, actually the disability certification issue comes at that time. But with this question of whether it is CP or not, if we consider it as high risk, we usually discuss with our pediatric neurologist, and in our hospital we have a full well established DIC center and a child developmental center, and also in all the medical colleges we are having district centers. So we register in them, and they follow up there, and every few months based on the child's condition, the neurologist asks them to come for follow-up, and that's how they are kept. So this question of disability certificate arises in our setup, as per my experience, only a little later, ma'am.
So I think by that time we have reached the age where we are legally capable of labeling a child as CP or non-CP. So probably it should not be creating problems for disability certification.
Yes, ma'am, as of now. Yes, as of now.
So that's a good thing you mentioned about DIEC, which means we are talking about early intervention. So what is your practice? Like we have high-risk newborns and you start detecting children who have problems. So what kind of intervention do you advise an infant or later? What would you do?
Yes, ma'am. With regard to this early intervention, actually the concept has changed over time. Initially, we were talking more about the physiotherapist-initiated interventions. When we did post-graduation, we were all taught about the various methods of physiotherapy, and more impetus was given to this Bobath, and that it is being followed. But now, after all this volumes of literature which have been published after CP registries registering numbers running to 4 digits and 5 digits and CP cases giving recommendations, now there is a paradigm shift from the physiotherapy initiated interventions to child initiated learning, the goal directed learning and task specific. It is more like I came across one study where it was a randomized control trial where it was like GAME, goals, activity, motor enrichment. So that is how the early intervention is said to be, it is said to be planned now. That is, for the therapist sits with the family, and for that particular child, what are the goals? That is discussed by the therapist with the family, and they set realistic goals as to how it has to be achieved, and the goal can be split into parts. So as every stage is achieved, they progress to the next stage. Like that. So for interventions, like during infancy, the early intervention has to start from the NICU itself. So from the NICU, we advocate kangaroo mother care, that is said to promote good maternal infant bonding. And then then for infants in NICU, they have to give at least 1 hour of noise-free period where the alarms are off, and gentle massaging, passive movement of the joints, and then having lighting in such a way that they can dimmed at night so that they simulate the day-night cycle. And these are some we can do in the NICU. And once the infant goes through the process, at the stage when the child has to attain head control, the mother is taught certain exercises, like she can put the child in the supine position, a small shoulder roll can be kept under the shoulder, and a toy which is very bright and colorful can be shown in front, so that the child has to crane the head a little to see. So in that way we can promote head control. Or if we put the child in prone position, of course any prone position should be under supervision. A toy which is kept a little higher than the head level will promote the child to look up. And initially we have to give support. The mother has to be taught how to give support, and slowly, gradually we can withdraw that. And for visual stimulation, we all know that the child can recognize faces at a distance of around 6 to 8 inches. So we should advise the mother to talk to the child. And when they talk, we have to tell the mother that it should not be a monotone. There must be differences in tone. The mother should show emotion. Because I felt it very interesting, because it is said that the newborns and infants can share our affect, it seems. It was an interesting point to read. So they should show emotions. And for visual stimulation, the babies can recognize contrast, and so in the baby's crib or wherever in the baby bed, on either side they can hang bright colored toys, so that apart from visual stimulation, if we hang on either side, the child will follow it. So visual tracking and following can be stimulated. And for auditory, again, mother singing to the child. We all remember that our grandmothers and mothers sang lullaby to us. So probably they knew a little more of early intervention than we put them in black and white like this. So like that, singing to the baby, and then exposing the baby to different tones. Like the mother's voice will be in 1 decibel, then a ring and a rattle, a squeeze toy, like that. So that will give a variety to the child and expose him to different things. And tactile stimulation, where the mother with the tender loving care, they have to massage the child. And even lying down position, the child should not lie down in the same position. We should make them to lie down on their sides for some time, and prone under supervision, and put them on different textures of bedding. If for some time, if we put them on a cloth mat, sometimes we can put them on a rubber mat like that, and some textured mattresses can also be used. And visual, auditory, and then with regard to the motor, again the motor stimulation, all that is task oriented. If we know that the child is having a hemiplegic cerebral palsy, we have got all this green light interventions for hemiplegic cerebral palsy, that is the constraint induced movement therapy and the habit therapy, which all have been proven to have good effect. So in CIMT, they restrain the hand for around 30 to 60 minutes, the papers are mentioning, for over a period of around 6 weeks, so that this, whenever the child does not use an arm, the brain develops something called as learned non-use. This is said to happen even in adults who develop hemiplegia. So the child will be encouraged to use the affected arm. And in this habit, they encourage the child to use both arms by giving skills like play-doh, where they manipulate with the fingers, and toys with parts which are mobile, so that they can manipulate with the fingers. And other than that, I think that is all I...
Yeah, there's actually a lot to discuss about early intervention, which I think is not really within the scope of our short panel discussion. But what ma'am is discussing is early intervention. As the term suggests, early meaning before a developmental delay develops. So early intervention is ideally meant for children who are identified as high risk, and the content of early intervention is promoting normal development at their normal ages. Like when you're asking the mother to do things to encourage the child or promote the child to look at different things, feel different kind of sensations, or try to control the head, we are trying to promote the child's achievement of head control by 3 months of age, which is what we want. So we are trying to intervene early so that we bring a child back to the normal trajectory. That is one of the things that you need to remember. The second thing about early intervention is it should be multisensory. Audio, visual, tactile, everything has to be done for every child. So that is what we mean about early intervention. There are lots of good books, and there is a lot to read about kangaroo mother care, infant massage, infant stimulation therapy, but I think we can just touch upon it in today's session. So with that, I think we should go to the treatment for a little bit. Yes, Dr. Vibhu.
So, while Dr. Priyadharishini was telling about what all a little baby can do, our Illingworth, which we are so all fond of, says that a 9-day-old baby, just 9 days, I just want to impress upon everyone, a 9-day-old baby, if you show that baby a scrambled picture on a paper or show a face, so slowly the child only looks at the picture of the face and not the one which is. This will tell you how much that newborn is capable. So if the child is capable, so how much we can all do.
Right. So one question towards the end of today's session is to Dr. Mahesh about drugs. What are the common drugs we use?
See, when you consider drugs for the management of spasticity,
Yes.
we use baclofen, even baclofen pumps, and for dystonia, trihexyphenidyl we use, diazepam we use. But most important thing is, before choosing the drug, ask the mother whether the child is having constipation. Because before using trihexyphenidyl, you may be going on increasing dose, child may be having severe pain with constipation. So you cannot use the drug at that time. And then most important aspect of management, apart from spasticity, is management of nutrition, management of the pain arising out of constipation or dystonia. So it should be taken care of. So while using baclofen, children usually will tolerate dopa. So in all patients with spastic diplegia, I used to give a trial of sig-dopa in any child, even the MRI if the MRI is normal. So if they respond, I will evaluate further. Number 2, baclofen dose slowly you will increase, and then usually the literature says you can go up to 40 milligram, 60 milligram, etc. But our children may not tolerate. Sedation is the most important part. If you go on increasing, the child may have excessive sedation, and therapy will get affected. So you have to optimize the drug individually. And baclofen pump is not practical in our setup.
Right. So commonly the drugs that we use in CP are drugs for treatment of spasticity or dystonia. Maybe a few drugs for treating the comorbidities, like we may have anticonvulsants for the epilepsy. If a child has a behavioral disorder, ADHD, we might be using drugs there. And one of the common drugs we also use is for cycling sleep. Melatonin, Finargan also we use as a very safe drug. So since we are close to the end, I think Dr. Vibhu, we must talk about the therapies, and since you are part of the North India CP Association, tell us a little more about what is being done by NGOs.
NGOs, I think, are one of the most important parts, one of the most important component of dealing with neurodisability, at least in our country at this time. And in Punjab, in Ludhiana, we have this North India Cerebral Palsy Association. Ashirvad is the name. So Ashirvad has been in existence for last 24 years now. And I am a part of this association for last 20 years. So these are all the people and staff we have. They're all grown up. We have 1/3 of the inmates. They have stayed with us. I mean, it's not a residential school. This is the early intervention unit we have. So we have all ages now. We have all ages, and this is a place where we do the typical multidisciplinary approach. I'm the pediatrician there. We have an orthopedic surgeon. We have the physiotherapy, speech and language therapy, special educators, early intervention. It is very, initially, even now for a long time, we have been working on the charity model of disability, charity model and medical model. पैसा दो हम दवाई देंगे और ठीक हो जाएगा, but now we all know that this charity. So
I think we have ended the time, but we can just take the last.
I'll just take a few, because we have now what we are doing is, since you said people are not coming, our workers, they go to the Anganwadis on vaccination days, because vaccination people are only doing vaccination. So our people go there, they are trained, they take weight, they do head circumference, and they do developmental monitoring. They ask about milestones. One thing more, the government issue vaccination cards are excellent. So people who are working in the government sector, even in the primary health centers, those cards are excellent. They have those green, blue and red zones. The green zone is what a particular aged child should be able to do. And reds are the ones, they are the danger signs. If your child cannot do, you pay attention. And blue is the stimulation which you all can provide. So kindly all students, everyone who is working in the government sector, please pay more attention to the vaccination and development cards which we have. And in our place, once we get a child enrolled, we are not really charging a lot. Our charges are not really big, just 3,000 a month. And we start early. We can, even if we find a child who has 3 months, seems to be spastic, we are not going to label anything, but we start with the stimulation there. And I am actually proud to be associated with North
So it
India Cerebral
looks
Palsy
like you're doing
Association.
excellent activity, and it builds upon the DIEC model which is recommended by the government. And in areas where we don't have excellent government services, I think having something like that would be useful. We have finished the time. There was a last question that I wanted to talk about was, what do we do with children who are transitioning into adults? We are able to make a diagnosis, we are able to do an early intervention, but at a certain stage when the child is 18, 19 years old, when other children would probably be going to college or thinking of their recreation, earning, we need to think about what are we going to do with the child with CP. So I
We
will
can
request you
leave
to
them
just
with
take,
the question.
yeah, just take 1 minute to answer this question, and can sum up the panel.
This is something which we are dealing with every day. There was supposed to be another question which I was to answer, and we could never get to it. So I know personally very well a 31-year-old male with cerebral palsy, spastic cerebral palsy, bilateral optic atrophy. He cannot write. He walks in an awkward manner, but he went on to complete his +2 from school, CBSE. He did engineering, BTech, computer science, and then from a triple IT, Allahabad, he finished his MTech. And he started working with GE in Bangalore. Right now he is working with Athena. So both of his parents, they are doctors. But for the initial, he is 31. For initial 3-4 years, 5 years, they never knew he had CP. There was nobody to give the diagnosis. He had all forms of seizures. So, but he doesn't have any ID. There's no intellectual disability. So, Jaswinder's story is something which inspires me. Every time I look at him, I am inspired to do more.
There can be a possibility of HSP plus spastic parapressive intellect will be preserved in such conditions.
But he has bilateral optic atrophy, and he was not given scribe. His parents had to go to PMO. In engineering college, they said we can give you scribe for 1 semester, 1 paper, 2 semesters, not throughout 8 semesters, not for drawing. So they went up to the PM's office, and in triple IT he had to write a dissertation. So it is the parents and we people who need to be smart about it and accepting not the disability but the ability. Believing that they can do.
Right. There would be many stories of struggles where the parents were able to get facilities for their children, but I think this should be universal and not just an anecdote for an individual family. I think with that we will end this session, and I hope we have been able to answer a lot of questions. And if there is still something more, our panelists are going to be available over tea and lunch, I suppose. Thank you so much.
Thank you. Thank you, Dr. Monika.
Thank you very much.
Thank you.
We've had the pleasure of listening to 2 wonderful sessions. I would now request our eminent faculty to proceed to the felicitation area to collect their mementos.